Okay, welcome everybody. We'll give it about 60 seconds at most, and then we'll get rolling here. Some folks are just now coming in. Okay, so I guess I can start with my piece, which is always the same. Welcome everybody to the Health and the Public Interest Weekly Seminar Series. We're starting our last month of the series now, 4 talks this month, and I think those of you who have come to join us from the outside will find that this is a great series that you'll enjoy a lot. We have wonderful speakers, and this last month is going to be quite something. And you'll be introduced to today's speaker in a moment. I just want to say that the Health and the Public Interest Program is a 1-year MS sponsored by Georgetown University. It emphasizes the non-clinical aspects of medicine, the social determinants of health, etc. And today's speaker is clearly going to tell us about some of the non-social determinants when we get to that. So the talk is going to end at 1 o'clock today instead of 1:15, not the talk, but the session. So Dr. Adams-Campbell is going to get started momentarily after a brief introduction by Yvonne Wabara, one of the seminar students that we're real happy to have join the Health and the Public Interest Program for this course this semester. Yvonne?
Thank you, Professor. So hi, everyone. My name is Yvonne Wabara. I'm a master's student in the Clinical and Translational Research program with a concentration in mechanistic and biomedical research. So clearly, I really enjoy learning about research. So I'm very excited to introduce our guest lecturer today, Dr. Lucile L. Adams-Campbell. Dr. Adams-Campbell is a professor of oncology and associate director of minority health and health disparities research at Georgetown. She earned both her undergraduate and master's degree at Drexel University, and she received her doctorate in epidemiology at the University of Pittsburgh campus. In the field of health disparities, Dr. Adams-Campbell's research focuses on cancers that disproportionately affect African Americans, as well as lifestyle interventions within minority communities. With over 240 peer-reviewed publications, her expertise includes cancer health disparities, cancer prevention and control, and cancer epidemiology. So please help me welcome Dr. Adams-Campbell as she presents to us on topics concerning cancer, aging, and disparities. Thank you.
Good afternoon, everybody. Thank you for inviting me this year to speak. And Yvonne, thank you for the nice introduction. Let me see if I can share my slides twice in a row. Okay. Are they up?
Yes, we can see them.
Okay. Okay, today I'm very pleased to talk to you about the intersectionality of cancer, aging, and disparities, a biological basis. I understand this is the health and public interest group, but I think that there'll be many aspects of it you can really have take-home messages with. So I'm a cancer researcher, so everything I talk about comes from that perspective. But when you think about cancer, or you have an interest in other diseases, chronic diseases, infectious diseases have become chronic diseases, it's really relates to all those types of diseases. So we'll hear a little bit about cancer, aging, and disparities. I know you've seen this a million times. People keep fussing and yelling about equality. We want equity. And make certain you understand clearly there's a difference between equality and equity. And you can see in this little chart, equal boxes does not put people at the same level to see ahead. Equity, you get the appropriate measures. You be more specific, more targeted approaches. And we talk about targeted and precision medicine, but these are targeted approaches. So here with the equity, the middle, you'll see that, you know, one person needs one box, one needs two, and one needs none to have that same sort of trajectory. But the reality often is a person left in the hole. How do we address these issues? Some of the hottest buzzwords these days are social determinants of health. We hear it all the time. We can collect a lot of information on social determinants of health, and we can talk about it and describe it, but if we can't do anything about it, then we have a problem. We know what they are, we know what the barriers are, we know how to try to get around the barriers, but if we do nothing, then there's a problem. And that leads to the reality. People get left behind. So as you see this, the accelerated aging and the social determinants of health on aging. When I talk about social determinants of health, it can come in different groupings. Here, I've just listed poor diet. We also deal with food insecurity, big issue. Poverty, how do you not stop talking about poverty when you want to deal with social determinants of health? Because they all come with a baggage, so to speak. Racism is very pervasive, more pervasive now than ever before, unless we go way back. Education, having low education levels, or being literate. And I don't mean just being able to read at 8th grade or 12th grade level, but health literacy is so important, so vital to what we do. But then we have this little funnel, and we have these biological transducers. If you're not into biology, we can pretend that it's just a little funnel. You come out on the other side and you have some aging phenotype. Everybody does not age the same way. There's a physiological aging and there's chronological aging. When we talk about aging in general, because I just got into this field of aging only because I got dragged in with my colleagues, I always thought about chronological aging, 65 and older, 62 and older, things like that. But it's really more than that. It's really about the physiological aging. Some people who are 50 may appear biologically in the way they move or respond to be 70 or 80. So those are differences that we have to think about. But the accelerated aging phenotype often leads to the health disparities and to shorten lifespan and health span. So we talk about disparities, and I talk about disparities a lot. All of these things funnel into increasing disparities, addressing disparities, showing disparities, demonstrating disparities. But the bottom line is it can shorten your lifespan and your health span. Let's look at the upstream and downstream. I know you're in the translational program, you probably talk about upstream, downstream. If you think about mechanisms, again, biological, thinking about mechanisms, we think about things that happen upstream and downstream. But here, we look at upstream factors such as race, racism, opportunities and resources, educational attainment. Those are upstream factors. But what happens when you add it with the downstream factors, such as health literacy, your attitudes, your beliefs, your personal healthcare behaviors? Physical activity is a topic that I study a lot because it's related to obesity. Obesity is related to many chronic diseases, and many chronic diseases lead to higher mortality and morbidity. Diet and mood, you see all these are downstream factors. What happens? It results in some adversity over the lifespan due to the combination of the upstream and downstream factors. And we get into weathering, but more importantly, shortened life expectancy. So here, discrimination plays a major role in laying the roots for disparities and health outcomes. And if you look here, look at discrimination is one of the root causes of accelerated aging. People tend not to think of it that way, but as I've said with chronic diseases, type 2 diabetes, metabolic syndrome. If you don't know what metabolic syndrome is, it's really comorbidities. It's having abdominal obesity plus some lipid abnormality, glucose abnormality, hypertension. It just combines them. So metabolic syndrome includes diabetes for some people. Some people look at metabolic syndrome without diabetes in it. Cognitive decline as people get older. You have this attention or cognitive problem that you have to deal with. Inflammation. Even when we talk about obesity, obesity is highly linked to inflammation. You can look at inflammatory biomarkers, you would see that. Early mortality, cardiovascular disease, risk factors, higher oxidative stress. But I just want to show you that aging is really, really, really tough. It's a tough field to study, I believe, because there's so many components to it. Let's talk about the ethno-geriatric imperative. And why do I think this is important? Because the numbers of older race ethnic minority cancer survivors are increasing. Before, we would always say, and we still say, minorities, Blacks in particular, have the highest mortality rate when it comes to cancer overall. So when we decide that we're going to do studies and treat people and come up with new drugs for people, and I do a lot of clinical trials, if we don't treat and include everybody, the people that really need it will not have access to the drugs that are available or the treatments and modalities that are available. So minority populations are growing faster than non-minorities. All race ethnic groups are living longer. And we know for a fact cancer rates increase with age. We know there are childhood cancers, but overall, as you get older, your likelihood of developing cancer increases. And if you live long enough, I'm sure you'll get something. There's a 99% increase in older minority survivors expected versus 31% for whites by 2030. So just knowing that little tidbit of information, it's a population that definitely warrants attention, warrants inclusion, warrants people to address the social determinants of health so that they can be included, invited, and benefit. And when everyone benefits, everyone else benefits as well. So the implications of minority aging for older cancer survivors compared to whites, older minority cancer survivors have lower rates of receiving recommended treatments. When you get to a certain age, people don't want to treat you because they're afraid to treat you. They don't know what the outcomes will be. That's because people have not been engaged and involved in perhaps clinical trials. There's less survivorship care. If you hear about nursing homes and places, probably places you don't want to put anybody, that becomes a big issue. And can people afford to put people in homes? There are greater declines in people's function, more fatigue, there's worse stage specific survival, and disparities are exacerbated by low enrollment into clinical trials and studies. I don't know if the happy people get involved in clinical trials, people that are outside of the happy program, but it's really important, I think, that for the public health interest, that they understand trying to engage people as much as possible is really important. And there are a low number of scientists, especially minority scientists, focused on aging disparities in cancer. And the reason that Georgetown, we have an aging program, which I'll tell you about shortly, but there's so few people interested, so few people involved, but in general, not just minorities. This was focused on minorities at the time. On average, minorities age faster than non-minorities due to many complex multi-level factors. Higher chronic life stress. If you think about the stressors that people undertake or experience, particularly discrimination these days, there are greater comorbidities, multimorbidities, and there are more limits in opportunity and access to care. So cancer and treatments are disease drivers of aging. So what can you do? How do you impact aging? And I don't know if in this program, maybe I'll ask Dr. Myers, in this program, do you have people that focus on aging at all, or do they do capstones in this area? Or do they, is anyone interested in this aspect of life? Because I said, I just came into it because I was pulled into it, but we do see people getting older and older at a time.
So we definitely have several students who's primarily interested in aging this year. So yes.
Okay, I'll keep that in mind. So here we go back to the social determinants of health. I just want to show you, when I talk about aging and life expectancy, all these things can happen. You know, you probably know more about genetics or hear more about genetics and aging disparities, but here you look at the life expectancy. I remember reading and knowing that the life expectancy used to be under 50, way under 50. And before, children, the little J-shaped curve, children, if they could make it to 2, they would live a longer life, especially in developing countries. But now we have this huge problem at this end of the spectrum. And this end of the spectrum is important, but we don't typically include people who are elderly in studies. There are a few big studies out that have been done. The Women's Health Initiative, if anybody knows about that, they were all postmenopausal women starting at the age of 59. I think we're in the 25th year of that cohort. So that's one of the big elderly studies. Now it's elderly, before it was just postmenopausal women, but the life expectancy goes down. The factors, I'm going to explain, factors leading to epigenetic age acceleration in minority populations. Psychosocial factors, demographics, and lifestyle factors. Let me just explain the concept of epigenetic in a very simple fashion. If the lights are on in your place and you flip the switch and turn them off, you've done no damage to your circuitry. That would be how epigenetics is. It doesn't damage your DNA, but you have a little switch on and off. So if you turn the lights on, you found out there was no damage done when I turned it off. So there's a little epigenetic factor that processes the psychosocial factors such as lifetime stress, discrimination, adverse neighborhoods. Neighborhoods are very interesting because there was such that history of redlining. And even now where people live, is there a lot of segregation where you are? Are the lower income areas filled with environmental toxin? You know, people put more pollution, more things in certain communities that would not be allowed in Georgetown, at Georgetown. So we know those types of things happen. Race and gender play a role. Lifestyle factors, as I've already said, education, obesity, smoking, alcohol, they all play a role in aging in terms of the stress response, in terms of inflammation, and other things. But just knowing that these factors do cause major problems as people get older. Now I'm going to take you to what I do mostly, and that is clinical trials. How do we go forward? What's the way forward? One thing is we have to acknowledge earned medical mistrust. A lot of people don't participate because of the medical mistrust that they have with their institution, their provider, whoever. And they also don't feel as though they are invited or included. And that could come from the provider-patient relationship. So we have to embed community voices in the process. We have a huge community outreach and engagement team, which is a central component of a cancer center. All the cancer centers across the country that are NCI, National Institute of Health designated, they must have a community outreach and engagement team to do it. We have to have viable clinical trials teams that are really interested in working and coordinating with the outreach team, because our outreach team really does embed community voices in the process. We establish community advisory council members and boards, and we have them come and tell us what is needed and how we can work together and how we can make some projects and research successful. We have to coordinate our oversight accruals, meaning we want to make certain that we're not just getting the high income, particularly white patients, and no one else. We want everybody, not one group, we want everybody. And we have to use knowledge of various to develop trials and expand to other groups. And develop trials that are, or studies, I say clinical trials, but develop studies or activities that are relevant to the needs of people in your catchment area, in the area that you serve. And we always are working on increasing minority accruals. And just so you know, at Georgetown, we have the Minority Underserved National Cancer Institute Community Oncology Research Program that I lead. And that is to ensure that Georgetown participates in the inclusion of minorities in clinical trials. And there are many types of clinical trials. People often think about cancer clinical trials. If I'm dying from cancer, I need a clinical trial. You can have a clinical trial to prevent you, to get you to stop smoking, to increase your physical activity. It could be for treatment. It could be for palliative care. It goes across the entire spectrum, but it's just important that one understands that we need to continuously engage in these circles, the clinical trials program or research program, the providers, and the community teams. And our community outreach team is pretty well respected nationally. I think we do a great job at what we do. So I always show this slide because if our patients are so diverse, we have diversity at Georgetown and Hospital Center, at the MedStar sites, and across the country. There's a lot of diversity. But again, I focus on the overall low participation of minority groups. And it limits opportunities for disparities research. It also limits opportunities for us to have success as a country. We need to do something about these things. I'll skip that one. So I just want to ask, maybe I can ask a few questions. How important is it that you document race yourself? If you go to the hospital, the patient identifies themselves, self-report, or if the provider or the nurse identifies you. Any thoughts about that? Why is it important to have, some places don't even allow race to be documented. Do you think there's a value to that at all? Anybody in the class?
So someone must have a, go ahead.
So
Ella?
I was, oh, sorry, Ellie, you can go. I'll go after you.
No, you first, you first.
Okay, well, I would just say, I know for me, when I worked as a research coordinator, it was important to have race because some of the averages for certain measurements, it differed between the races. So for example, I worked in an asthma study and we would take lung function tests, and lung function values were different from Caucasians than they were from African Americans. And so if we didn't have the race, then the averages would seem off or the results would seem off. So that's one example I can think of just for technical issues.
Somebody else had a statement?
Oh yeah, that was just me. I just was a lot of what Yvonne said, but then also about self-identified race versus maybe perceived race between the patient and the nurse, and how they identify that could have its own issues. But that's what I was thinking.
Well, a patient was admitted to a hospital. And there's some drugs, I will tell you that there are big differences in certain things between groups. I don't think it's biological, but in the end, their whole genetics plays a role sometimes. But patient admitted to the hospital, African-American, Black, self-reported. The discharging nurse designated the person as white. What do you do? When the person checked the patient out, they were declared to be white. These can cause a lot of problems because we don't know what we're doing when we do that. So self-reported, but I was just giving that example because that example was my mother. And I wanted to know what did they do to her in the hospital that converted her to white from Black. So I just had a personal problem with that. So here, these things are very important as we go forward. You won't catch on, but that's actually me, my daughter, my mother, my grandmother, my great-grandmother, my great-great-grandmother. So when I look at this, we know that mixture exists. That's how come reporting race is only a social construct, and we should not go beyond that. Because biologically, if we do admixture studies, and we can find Indians and whites, we can find all this in our blood. So it's just important to think about that for study's sake. I can't get this working right. So here is something that we should just think about in general for anybody, any group, the hidden risks of being poor, the poverty premium in insurance. Can you participate in research really without insurance, clinical trials in particular, without insurance? And we need more clinical trials in the aging populations. can we really do it if they don't have insurance? Or does everybody who has over 65 has Medicare? But they don't pay for clinical trials. Some states have state laws that will allow for clinical trials to be conducted and be covered by the state or by the institution, but under certain laws. DC does not have that. You have to have insurance basically, unless the study covers all the costs, but that would not be a treatment study. That would be a prevention or control study. But insurance really, I think insurance is a big issue because Georgetown doesn't accept every insurance policy that's out there. You can have an insurance card in your hand, but you might not be able to get the care that you want because there are different levels of insurance. So just thinking about that. But anyhow, I want to move on to some other issues that affect participation and in studies, clinical trials. I'm, as you can tell, I'm a clinical trials person, but cultural competence, we don't often address this issue. And I think that's often the missing variable as we do anything in life. So cultural competence requires that organizations and their personnel have capacity to value diversity. We're now on this big DEI thing, diversity, engagement, and inclusion. That's all over Georgetown, all over the country. It's about valuing diversity. You have to think about how real is it? And how do we value diversity? We have to conduct self-assessments to see where we are. I think of diversity, intellectual diversity, racial, geographical. There are a whole host of ways of looking at and valuing diversity. If everybody comes from the same side of the street, that's not diverse, but we need that diffusion. Conduct self-assessments so we know where we are. And we have to manage the dynamics of differences, not through fist fights and things of that sort, but through actually engaging with people. Acquire the cultural knowledge, the institutionalized cultural knowledge. That's a little interesting when we talk about cultural knowledge at Georgetown. It's a big difference from some other places, I guarantee you, because we have the Jesuit career personalis. We have these different ways of life, supposedly at Georgetown, and adapt to diversity and cultural context if individuals and communities are served. And when I talk about cultural competence, when we reach out to different communities, I can't go into a Hispanic community and pretend that I know what's going on. I have to make certain that our community representatives really can parlay information back and forth, and we have dialogues so that we can actually come to the table and offer something that people will benefit from. And I think that would be very helpful. We also have to recognize that one size does not fit all. And we see this a lot. People think that everybody of this group is the same. We're not. Everybody who's 65 is not the same. Everybody who's 75 is not the same. I saw on TV somebody is dancing at 103, no walker, no wheelchair, no cane, anything. And somebody at 75 is wheelchair bound. So one size does not fit all approach. We rely on representatives from the communities, as I've already told you, and diffusions of innovations that we look for agents of change. I really work so hard in the community to try to make certain that we get people that are interested, and if not, we have programs. We do faith-based programs. We do town halls. We do a lot of things to get our community engaged. If we don't engage the community, we can't do our work. And I think that with HAPPY, I'm really curious to hear from some students in terms of how do you move forward with your focus? How do you go forward with knowing about public interest? Do you have a community approach to life, or is it all scholarly through literature? I really have no idea, so I would be very curious to hear what that answer is. And strategies in applying a cultural competent approach. Linguistics is very important. You have to make certain that you're speaking the language, not just the language, whether it's a foreign language to you, but the language in general, making certain that people connect and understand what's going on. Identify community agents, translate and disseminate information. When you get people in your studies or people engage with you, do you ever tell them what really happened in the end? Do you ever disseminate any information back to the community or to whomever you're working with? And I've hired community members to assist with studies. That can go one of two ways. It can be good or it can be bad. You can hire community members that are so engaged that they want to know too much about their community members, so that doesn't work too well. And you can hire community members that really are right appropriately based for you. And using community-based participatory research approaches is important. At times, I do community-based approach and I do CBPR approaches. And having those mixed method approaches are important when you need to talk to key leaders in your community. Now, when we get to aging, that's a tough call, but there are many societies, many organizations, many groups of people that have been together for a long time. So they form these aging cohorts, and you talk to them and you meet with them and you interact with them to get where you want to go. But without meeting with certain groups, you don't get anywhere. So I just want to tell you about this GLICA. I don't know if anybody has heard about this, but this is Georgetown Lombardi Initiative for Cancer and Aging. This is what is led by Jean Mandelblatt, if you know her. Dr. Mandelblatt is a real pioneer in aging and very successful researcher at Georgetown, and applies knowledge about aging across the lifespan to improving the lives of our cancer patients and their families, and it's to achieve equity in cancer outcomes. And you'll see in this little circle down here, stress adaptation. I don't know how much biology you really focus on, but the idea is that there are multi components and ways of really impacting aging in the population. So we have a new grant, and because HAPPY is a program, if you have anybody interested in aging, we have a new grant called iReach, Infrastructure for Research in Equity, Aging, and Cancer and Health. And the goals are to provide core resources to accelerate knowledge about how differences in aging affect health and health disparities in racial ethnic minority cancer survivors age 65 and older, and to recruit and train diverse scientists in aging disparities in cancer. Well, we have spots and places for students, for faculty, for providers, for organizationals, for stakeholders in the community. And what we're trying to do constantly, and this grant is in year one, we're trying to get more people engaged in aging and cancer. So I don't know if anybody in HAPPY is involved in cancer and aging together, or if there are any interest in any of those items, because that was something that you might be able to embark upon. So from the aging perspective, I just wanted to give you a brief, this is really a brief talk, because I really wanted to have a discussion about where we could go in terms of HAPPY and even our program in epidemiology. How could we come together and do something in aging and cancer and health? So I'd like to open this up really for a discussion, because that was my plan all along, and find out if there's any ideas that would come across people's mind that could be expanded on, that could be a capstone, could be for my group is a thesis. So I want to stop there and ask if you have a little discussion about aging in general.
So Yvonne, if you're able to take over.
Yes. So I do see one question from Eileen. She asks, how do you reconcile these two concepts? So this is concerning race. race is a social construct and does not have a biological basis. Example, no basis for calculating kidney function based on race versus the importance of including racial diversity in scientific studies. Do you have anything to add, Eileen, to your question?
Well, you said for kidney function in particular?
Yes, this was concerning kidney function, your question.
That's interesting, because I think if you look at the literature very carefully, Blacks have the highest rates of hypertension, highest rates of kidney failure, highest rates for being on dialysis, lower rate for getting a kidney transplant. And the lower rate for getting a kidney transplant is tied to the fact that people there have not been a lot of donors. There has not been a lot of matching and studies done in Black communities. So they are last on the list typically for matching. So how do I reconcile that race is not a biological construct the way we use it, but in terms of kidney function and some other things, based on the literature, it's proven that it works out very well in terms of, at least from that phenotype of being Black. That phenotype is heavily linked to the outcomes that we've seen with the kidney function. I don't try to mix them, but as long as we are acutely aware of how we're using race, and for the purposes of that medical work, it pans out because of the literature that that phenotype actually is linked heavily to the outcomes that we see. It's really looking at that phenotype in that case. But people are now doing Duffy exams, measuring admixture, doing more that way. But in general, if you look at any paper, unless they're geneticists in general, and now more genetics are coming about, if you're not a geneticist, people are just using race the way we know it is self-report. And it's even worse if it's not self-report. So phenotypically, it proves that it comes out that way in that case.
Thank
when you
you.
talk about lifestyle, when you talk about lifestyles of how people live, then it has another connotation too. Go ahead.
Thank you for your response.
So I'm hoping some of the students can contribute to these discussions, but I have a quick comment, Lucile, and that is that we're going to have another talk on race and medicine at the end of the series. So, we'll have another shot at teasing out some of these issues, but quick question from me, Dr. Adams-Campbell. So if we're talking about self-identification versus, clinical staff identification of racial background, it gets pretty dicey, right? Because if someone considers themselves of a particular race or ethnic group, for all practical purposes, they don't stop and try to parse that out. They're not trying to look at somebody and make guesses who they are, right? And but on the other hand, if you look at the genetics, it could, or the family history, it could be, 1/16 of that ethnic group, or it could be 100%, right? So I guess, am I right in saying that if you look at the self-identification, what you're saying is that it ties pretty closely to how others might identify them, and therefore how the system might affect their outcomes, impose disparities, et cetera. Is that fair to say?
Well, you're basically saying that if they identify somebody who's a minority, the outcome could be unfavorable.
No, what I'm saying is that the disparities that are associated with a group are, in a way, they're not genetic. I think you pretty much said that.
Yeah.
So that if you
Right.
look at somebody's self-identification, it has to do with their place in society and the disparities that are imposed upon them. Is that a fair statement?
That's a fair statement.
Okay,
That's a fair statement. It's about that lifestyle, the social constructs. Yes. That's a fair statement.
And it's a society then that imposes those things.
You think about music, when you hear a certain type of music, it's automatically viewed, certain ways compared to other, other music. Same thing. But I want to ask about aging. I want to ask, is there anybody interested in aging? And I would like to hear a perspective that people might be interested in aging. I'm interested in aging from the clinical trials perspective. I want to know if somebody is 75 or 80, should they be put on a treatment trial if they have developed cancer, or should they be left alone? If they have cancer, they need to be treated anyhow. So how do we get people into participate in some of the cutting edge studies? That's where we go wrong, or we don't have the involvement. But also, aging and disparities aging and minority health have so much in common. When you are a minority, particularly Black, many comorbidities. As you get older, many comorbidities. So it's almost like you start off at a young age, and you have a minority, and you have a lot of comorbidities, a lot of health issues. It's just a fact. It's known, well known. But then, as you get older, whether you're white, Asian, whatever, you end up with comorbidities. So you almost end up trying to study the same thing. I have a problem studying minorities in clinical trials because they get excluded because of their health profile, because it's important to keep safety at the forefront of your studies. And if you get older and you're aging, you get excluded because you have too many comorbidities. They're afraid something adverse will happen to you. And Yvonne, you're in the clinical translational program. Have you gotten to those things yet?
No, my capstone is actually focused on pediatrics, so the opposite end of the spectrum. But we do have two hands raised. So Brett, you can go first, and then Ikeda, you can go right after him. Thank you.
Thanks. Lucile's a collaborator of mine on something else, but you asked for people interested.
Before you say one thing, I'm just going to say, last night I just learned that your father is the person that I went to the Isle of Capri with to give a talk with.
Oh, is that right? Yeah.
I didn't know you were related.
Yeah, we're related. And in fact, we've written some papers together. So any of you junior folks out there who have scientists for parents, you never think you're going to collaborate with them. And I didn't for 50 years of my life, but I've written 3 or 4 papers because there's an overlap interest, which I'm going to bring up right now. That I have.
Just to say that his father is a famous scientist at NIH.
He's over at NIH. He's a big P53 researcher and goes all over the world studying different cancers. But he approached me, and I'm really interested in brain cancer. And most people who get brain cancer are pretty old, and so they kind of follow in the older age category of cancer, and they do get treated. They get cancer, they get surgery, and they get chemotherapy or radiation therapy. And I'm really interested in kind of the morbidity of radiation and chemotherapy to older folks that have brain cancer, because a lot of people unfortunately have cognitive problems. They're surviving their cancers maybe, but then they have the cognitive problems later on that can last with them for a long time. And so that's one of the areas that actually both my dad and I are studying together, and might be of interest in collaborating, Lucile, on.
Yeah, and we should talk about that in detail. But it's interesting, the 2 people I knew, I was director of Howard University Cancer Center, and when I was there, 2 people developed glioblastoma, brain cancer. One was in her 50s, and one was in their 70s. They both were blonde. And just curious, I mean, that's not elderly. I mean, that's not elderly, but 2 people developed it. And one lived a year and one lived about a year and a half.
Yeah.
But what would you do with radiation? Are you looking at the impact of radiation on cognition?
Yes. So we're looking at the biological level at tissues from people who've had their first resection, They get radiation and treatment, but then they have a second resection, and we're looking at the tissues to look for senescence markers in the tissues related to either the cancer or to the radiation therapy, and trying to understand what happens to the brain with these treatments that are sometimes life-saving, but then maybe provide some detriment in terms of how well your cognitive abilities are. So, I mean, our goals are to live longer, but we want to live longer with good quality of life. And so understanding the kind of the pathobiology of how these treatments affect the brain is one of the things I'm really interested in.
So are you part of our iReach program? Are you going to be? And you know Jeannie Mandelblatt.
Yes, yeah, I've attended a lot of the GLICAs, so I'm going to stop there. We can talk more offline.
Great. Well, that's very interesting. Thank you, Brent.
Thank you, Brett. And Nikita, you can go next.
Thank you so much, Yvonne, and good afternoon, Dr. Adams-Campbell. So my name is Wakitsa Spriggs. I'm a grad student in our Aging and Health program at Georgetown. And so, I'm very interested in aging. From my view and study, it's not on the clinical side. So I have a passion in the housing domain. And so that's one of the concentrations that I've done here. However, I am passionate around studies and participation. And so one of the things that I want to do is advocate for the community to be more of a participant in studies, because I think at 75, I don't think you should participate. Now, how we get people to do that, that's a choice, but I think we should have an older adult participate at 75 in any study if they can. That's my view.
Would you like to be involved in iReach, or are you already involved in iReach or GLICA?
I am not. I would love to talk to you about it further.
Yeah, I just wrote down your name. We can look you up. But I think if you're interested in aging at Georgetown, some really strong people involved. And I hear what you said about housing. That's how come the stakeholder perspective is exactly where you fit in, because you're interested in that community side, the housing and probably that community just at large, how you work with it. But that's all a part of it. We do have interest and involvement with that. So what degree are you getting?
It'll be a MS in Aging and Health with Dr. Pamela Saunders.
Oh, I couldn't think of who it was. Okay. All right. But yes, that's a possibility. We do because we want stakeholders involved. We want to hear and advocacy. Advocacy is very important. And if we don't have advocacy, we can't do anything. So I know Pam Saunders well. Okay.
Thank you.
Any other questions as to what can be done? Or what you could do?
Ella has her hand raised, so you can go ahead, Ella.
Sorry, it was not letting me unmute. I just wanted to get you to speak a little bit more on the intersection between physiological health and chronological aging and health. I think the discussion on that just needs to be a little bit more understood within the public consciousness. And it's not something we talk about, whether that's allostatic load or, how people are aging and when that intersects as people are older and how, anyways, you touched on it before. I just wanted you to speak a little bit more. And then on the clinical trials and HAPPY, we talk a lot about how clinical trials often only include healthy people and those who do not have any comorbidities. And so then by the time the drug hits the market, you see a lot of interplay between drugs and, challenges to people who are older. But just on those 2 points, that was all. Thank you for your talk today.
Well, that's interesting, because the talk at 1 o'clock is on allostatic load, the physiological burden on your system. And that's exactly what aging is all about too, whether it's stress, whether it's, Actually, I wish I could, I'm gonna stop sharing this for a minute. If we think about whether it's the environmental stresses, whether it's major life events or trauma abuse, or how there are individual differences and their behavior responses, and it's all perceived stress. Like, do you feel a threat to helplessness or vigilance? And this physiological responses, whether you adapt or not, or whether you increase your allostatic load. And when we talk about allostatic load in general, we really go from a chronic physiological psychosocial stress all the way through. You have the activation of the hippocampus and SAM system, the secretions of the stress hormones and inflammatory markers and physiological dysfunction. These are all paths to psychological stress that leads to disease. And we talk about allostatic load, it comes from like primary mediators such as the neuroendocrine system, secondary systems such as the immune, the metabolic, as we've already talked about, cardiovascular, anthropometric, obesity. We talk about waist to hip ratio and body mass index, things of that sort. And then there's some tertiary outcomes, poor subjective health, disability, cognitive decline, there's cellular aging and diseases. So all of this is how you look at how you look at allostatic load. And actually, I'm able to show that when you think about allostatic load, you think of in general, the immune system, the cardiovascular system, the metabolic system, all coming together. And as you get older, that's exactly what happens. You know, your metabolic profile is not as good as it was when you were in your 20s. Your immune system often can become compromised. And then the cardiovascular system, we know as you get older, your blood pressure sometimes, most times tends to go up. I don't know how many people are hypertension free as they become an older person. So those three parameters in general really impact allostatic load. And when you think about chronological aging versus physiological aging, if you have all these aberrant things happening to you in your immune system, cardiovascular, and metabolic system, impinging on what we know as allostatic load, that I think is one of the biggest reasons and sources behind having physiological aging versus chronological aging. So did that answer any of your questions? So that's actually what I'm talking about at 1 o'clock. It's all about allostatic load because it spun off of a project that I did on metabolic syndrome. And then when you started thinking about allostatic load, it's become popular. And right now we have just, probably 3 months ago, just got a new R01 grant on allostatic load in the Women's Health Initiative, which is in the elderly population now, doing analysis with that group. So glad you asked that question because the allostatic load is important. And most people don't hear about allostatic load at all. But
it was one of those terms I've learned since being in this master's program that I'm just furious I didn't know years ago that, but yes, thank you.
No,
Glad you could speak on it.
Yeah, it's very important. And we can show that certain things help reduce your allostatic load. What is it? One thing is exercise. Like I said, I do a lot of physical activity research. Exercise reduces allostatic load. So you see, even when Ruth Bader Ginsburg was still alive, she had the little 1 pound. She was doing all this pumping of irons with her little 1 pound with her trainer. She lived a long life and she fought up 2 or 3 cancers, you know, exercise. My mother is 99. She has a 1 pound weight. I find it the funniest thing. I see her lifting a 1 pound weight and I pick it up and almost throw it away. But it's important that you do something and knowing that it reduces your allostatic load, it's really important. So when it reduces your allostatic load, it's reducing burden on all those systems at one time. Thanks for asking that question.
Thank you, Ella. And we have another question from Waikita. You can go ahead, thank you.
Oh no, I'm good.
Okay. I have a question then if no one else has one. So my question is, in the decades that you've been doing research in health disparities, where have you seen the greatest area of improvement? And why do you think that is?
Said it again, sorry.
So since you've been doing research in health disparities for so long, what area do you believe has improved the greatest and why do you think that is?
I think the biggest disparity gap that we have really narrowed has been with breast cancer screening. And I say that because when I started many decades ago doing screening, advocating for mammography screening, the rates for Blacks getting screened were dismal, very low, and for US whites were very high. Now there's no difference in screening rates between Blacks and whites. And that has been great because it's resulted in more early stage diagnosis than late stage. So to me, from the work that I have done for about 4 decades, those rates have declined. Now we're expanding what we've learned for breast to lung and colorectal cancer and prostate cancer to see if we can make those differences as well in other disease groups. But the screening and navigation has been very important. I know those of you who have read literature, Harold Freeman in New York, the father of navigation, has shown that if you navigate, we have lay navigators, community navigators, if you navigate people through the system, you also can make a big impact. So navigation has really come up. In terms of exercise, since I do a lot of exercise and obesity research, the biggest disparities is still there. Obesity is a major problem. We can do exercise, but now they're coming out with pills that make people lose weight really quickly. And I often wonder if that's going to cause more mortality, increased mortality, or more damage than we know of right now. So navigation, screening, early detection has had the biggest gap, has bridged the gap between survival, race differences in terms of certain outcomes.
That's great news. Thank you so much for sharing. Does anyone else have any questions?
No questions. Okay, well, thank you for inviting me.
Thank you so much for giving a great presentation. I learned a lot. I'm sure everyone else did too.
Thank you so much, Lucille. We'll look forward to seeing you here again in a couple of years. And your talk today was enjoyed by all, I'm sure. Please join us, all of you, for 3 more seminars this month. And I assure you, they're all going to be spectacular. So Lucille, thanks for starting off this month in a wonderful fashion.
Oh, let me just add one thing. In about 12 days or so, Georgetown will have the Ralph Lauren Center for Cancer Prevention will open. We'll have a ribbon cutting for that. And that also is a testament to our screening and navigation success in addressing disparities, because the Ralph Lauren has given a lot of money for us to become this new center. So I'll invite you after the ribbon cutting. Can't get in for the ribbon cutting, but I'll invite you afterwards. But thanks for everything, Dr. Myers.
Thanks so much. See you all next week.
Thank you.
Bye.
Bye.